Good evening, all. Today I'm continuing my part two lecture of oral habits. We will go through tongue thrusting habits. The abnormal positioning of the tongue. Now, what is tongue thrusting habit? The abnormal positioning of the tongue anteriorly to varying degrees have been termed as a tongue thrusting habit. Now, what happened is the tongue thrusting habit is the most controversial of all of the oral habits. Some consider it retained infantile swallow, a harmful habit causing a malocclusion, while other believes it as normal and that the soft tissue adjusts to the endoskeletal complex rather than vice versa. Now we have the classification according to the Moyers using EMG research have classified that problems into simple or tongue thrusting and complex tongue thrusting. Simple is defined as a teeth to teeth contact during swallow, the malocclusion usually associated with the well circumscribed open bite. And as we all know, open bite is due to the tongue thrusting habit. The complex tongue thrusting habit is defined as a tongue thrust with the teeth apart swallow. The malocclusion seen with the complex tongue thrust has two distinguishing features, poor occlusion and generalized anterior open bite. Now, third is retained infantile swallow. Retained infantile swallow is the condition where the child actually has his swallow pattern when he becomes an adult. It defines an under persistence of the infantile swallow well past the normal time. Very few people have a retained infantile swallow. Those who have ordinarily occludes on just one molar on each quadrant. Then also demonstrate strong contraction of the facial muscles during swallow. The person with retained infantile swallow do not have expressive face since the muscles of seven cranial nerves are being used for the massive efforts of stabilizing the mandible and not for the delicate facial movements of facial expressions. They also have serious difficulties in mastications and may have low gag threshold. Abnormal tongue posture. There are two forms of protracted tongue posture, endogenous and acquired. The endogenous protraction tongue have a tip of the tongue lying between the incisors. The great majorities of endogenous protracted tongues are not an aesthetic, and there is stability in the incisors relation, even though a mild open bite exists. The acquired protracted tongue is in more simple matter since it usually results from chronic pharyngitis, tonsillitis, or other nasopharynx disturbances. Thus, once the etiologic factor is removed, the tongue posture is resumed or to its normal position. According to Bouncer and Townsend's and Holt, there are four types. Type 1, non-deforming tongue thrusting habit. It means the integration of the tongue and the profile were acceptance within the normal range. The tongue pattern apparently is non-deforming and the nature and because of the sufficient tonus of the lip and the cheek to prevent deforming change. The type 2 is deforming anterior tongue thrust. There are some subgroups that is anterior open bite, anterior proclination, associated posterior cross bites. The subgroup 1 says the tongue is thrust and the force between the anterior teeth during swallowing that tends to incisive and or a lack of eruption of those teeth and spacing through which the tongue protrudes. Subgroup 2 says depending on the superior inferior level of the thrust and the posterior position of the tongue, various type of deformities are seen in the subgroup. When the tongue is thrust directly through the anterior opening, creating by allowing the mandible and open slightly during swallow, a force is directed against these anterior teeth approximately 1 or 2 times a minute. The associated deformities observed may be by max protrusion, while these anterior teeth have been rather high degree of angular protrusion towards the maxilla. The usual results of procumbence of the maxilla is, however, the tongue is thrust primarily directly anterior associated with class 2 Div1 malocclusion. Type 3 subgroup says deforming lateral tongue thrust. It limits the posterior region And it is type of 3 in which it sees the tongue literally between the posterior teeth and the resultant posterior open bite and often and associated with posterior crossbite. Now, type 4, deforming anterior and lateral tongue thrust. It can be a mild or quite devastating in nature during swallowing. The tongue comes in to cover the occlusion and the incisor surface or to the teeth expected. Second molar, usually this is associated with a large tongue, decreased degree of control of tongue, such as cerebral palsy or other neuromuscular diseases. Etiology of tongue thrust habit. It may be genetic, learned behavior. Learned behaviors includes improper bottle feeding, prolonged tongue sucking habit, prolonged tonsillar or upper respiratory tract infections, tongue held in open spaces during mixed dentition period, prolonged duration of tenderness of gums or teeth can lead to change in swallowing pattern to avoid pressure in the tender zone. Now, maturational, mechanical restrictions, neurological disturbances, psychogenic factors, tongue thrust can sometimes occur as a result of forced discontinuation of other habits like thumb sucking habits. So sometimes a patient quit the habit of thumb sucking habit and take the charge, and the tongue thrusting habit take the charge, which may be worse. Diagnosis consistent of the detailed examination of the tongue, then morphologic examination to be done of the tongue. Asymmetric or symmetrical changes can be seen or can be noted. Size of the tongue should be noted, and size of the tongue in which microglossia or macroglossia can cause. The condition where macroglossia commonly occurs is myxedema or cretinism, uh, Down syndrome, acromegaly, muscular hypertrophy, congenital problems, and tumors may cause macroglacia. Now, functional examination to be done of the tongue, displacement, and the observation of the postural position of the tongue while the mandible is in its postural position. This may be done by the cephalometry. So, with the help of cephalometry, we may know the position of the tongue at the rest. So these are the type of tracing for the analysis of the analysis on the lateral cephalogram to be done. Palatographic examinations of the tongue using palatography. There are two methods: direct methods and indirect methods. Now, two significant variation from the normal posture can be done: retracted or locked tongue, in which the tongue tip is withdrawn from all the anterior teeth. Now, protracted tongue, in which the resting tongue is between the incisors. The retracted tongue is seen in less than 10% of all children, but is often associated with posterior open bite since the tongue may spread laterally. The protracted tongue position posture may be endogenous or acquired. Endogenous, it means it has already with the patient, but acquired is due to some reason the patient has acquired the condition. Now, clinical diagnosis of a tongue thrusting. The patient is seated upright with Frankfurt horizontal plane parallel to the floor, tied to observe unnoticed several unconscious swallow. Patient is asked to swallow multiple times and unconsciously the doctor check if the swallow is normal or not. Then place a small amount of water beneath the patient's tongue tip and ask patient to swallow. Note the mandibular movement. If the normal mature swallow, the mandible rises as the teeth are brought together during the swallow with the lip touching. The facial muscles ordinarily do not show marked contraction of the normal mature swallow. Now, clinical features: proclination of the upper anteriors, retroclination of the lower anteriors, typical diastema, open bite, complete collapse of the maxillary arch may have been seen. Now, the management, the therapy causes when the malocclusion has been stable for several months or years and it's not serious enough for to warrant the orthodontic correction where patients and the patients and the parents are cautious to watch carefully, then the sign of change is severity in the malocclusion. But the patient demonstrate either though history of failure, speech therapy, resistance to therapy, or unwillingness to compile with the practice requirements as they are explained to him, the poor attitude towards the remedy of this problem in the patient with severe mental retardation, brain damage, or behavioral disorders. When the parents and the other responsible person cannot or will not observe the child and provides feedback to him and to therapist concerning his performance, the best stage to start the treatment is the mixed dentition by interceptive procedures called functional compensations. Now, the mixed dentition being the most frequent and optimal time for the therapy. Oral screen can be used, double oral screen can be used, modified bionator screened with advice to tongue pressure, prompt mandibular development with forward construction bite, and labial bow helps in retraction of upper anterior teeth. If the habit is noticed in its beginning, the stage, and the patient is willing for the treatment, can be advocated self-corrective treatment procedures such as acquire the patient with a normal swallow by placing the index finger on the tip of the tongue and then on the junction of the hard and the soft palate. Instruct the patient to place the tongue while swallowing. Psychological aspects can be used. Hay rake appliances. As you can see in the image, these type of appliances can be used as a reminder or comprehensive treatment for the tongue thrusting habit. Quad helix can be used treatment with bioactivators and headgears can be used. Active vertical correctors can be used. Frankel 1 or 2 and 4 can be used. Now the other is mouth breathing habits. The mode of respiration is examined to the establish of nasal breathing in impaired or not. Chronically disturbed nasal respiration presents in dysfunction or the orofacial musculatures. Now classification is obstructive, habitual, and anatomy. Obstructive means that something has been obstructed, the nasal passage, so the patient is formed a mouth breather. Habitual means the patient is having a habit. Now, first the obstruction was there, but the obstruction has been removed, but the patient acquired as habitual. He acquired or he or she has acquired the pattern of mouth breathing. So even though the obstruction have been removed, the patient habitually do mouth breathing. Now the anatomic, it means due to the anatomy, some anatomy, for example, swelled adenoids or some obstruction, the patient has mouth breathing habits. Etiology, deviated nasal septum, nasal polyps, chronic inflamed nasal mucosa, hypersensitive nasal mucosa, or in a chronic allergic rhinitis, localized benign tumors, congenital enlargement of turbinate, tonsillitis, adenoids which are enlarged. So these can be the reason, can be the etiology of mouth breathing habits. Now, mouth breathing related to thumb sucking and lip biting. The thumb sucking and lip biting are often accompanied with mouth breathing. Thumb sucking alone does not produce deformities beyond those of the dental arches and teeth, while the accompanied mouth breathing does much more harm. Now, maybe heredity, as some studies have shown that the heredity plays a very important role in habits in which mouth breathing habits may be carried in the heredity of the patient. A diagnosis, first, the patient is asked to relax and sit in an erect position. Now, the mirror test has been should be done, in which the mirror is kept between the nose and the mouth, and as we can observe the fog. If suppose the fog is towards the mouth, the mirror of at the mirror which is towards the mouth, the patient is mouth breathing habit has a mouth breathing habit. Now, butterfly and cotton wool test the placement of small cotton in front of each nostril. If it is pushed away during the expiration, patient is said to be nasal breather. And water test. The patient is asked to put water in the mouth and to stay and to inhale or exhale with the help of nose. If patient is mouth breather, he may or she may not be able to do this for a long time, and she or he has to swallow the water and to breathe with mouth. Rhinomammometry and respirometry can be done. Sedman's medical dictionary defines in a very nice way, like a study of nasal obstruction and nasal airflow characterized characteristics. Since this term refers only to nasal airflow measurements, the direct oral respiration measurements is termed as respirometry. The clinical effects and features localized, divided as localized, that is soft tissue and hard tissue, remote organs, and psychiatric effects. Local effects, cheeks and chins. The chins are resided, cheeks as the mouth is habitually held open. The cheeks are pulled downwards and becomes narrow and full like values with each respiration. The gingiva is hypertonic, inflamed, persistent marginal gingiva has been done, as the patient has. Mucous membrane, it becomes prolonged inflammation due to drying or irritation. Nasal mucosa is also disused and bacteriostatic action of nasal secretion is lost. And the pathway is permitted to the where disease, particularly viral infection, may safely enters the lungs. Speech, nasal tone in the patient of mouth breathing have been dull smell due to less nose secretion. Nasal turbinates are swollen and enlarged. Hard tissue inhibits growth of premaxilla. V-shaped maxilla. Chance of posture needed in accomplish this lower the mandible, positioning of the tongue downwards and forward, extending the head. The severity of the deformities depend on the age of the child, degree of adenoids and subsequent mouth breathing, duration, degree of cause. Now, remote effects, older child snore at right, difficulty in swallowing. Mucus secretion in the adenoid is swollen, is in large quantities and procedures, rearrangement of stomach and intestine with failure of growth and general health. Psychiatric health, psychiatric effects, general appearance, and accompanying malocclusion leads to an introvert personality. The management after first step is to look at an obvious or a definite cause of nasal obstruction and treat them, if any. After the ENT specialist have eliminates all the air passage obstruction, the first problem is to divide if the children should have immediate orthodontic treatment. Ballard thinks that there is seldom any need to embark of any treatment in the young child, as it believes to be an orthodontic treatment needed to be necessary as adenoid regress by age of 12 years. Preventive and interceptive of the habit can be done. Reminder therapy can be used. Cards of a piece of card held between the lip while reading, listening of to radio, homework, and at the end odd timing during the day is helpful to keeping the lip closed for the certain number of time each day. Exercises, lip exercises have to be done. A web exercise called Zero Oris exercise designed to reestablish the function and tonicity of the exercise to carry out by using first two fingers in the right hand. Alternative contraction and relaxation until the feeling of slight fatigue and experience repeated at least 20 years. Wilson's exercise, patient's routine should be taken charge. Masseter temporal exercise to be given to the patient. Orthodontic appliance like oral screen can be used. Frankel regulators can be used. And other habits, this nail biting, treatment is punishing, scolding, or restraining for the patient is done. Bruxism slide, that's this slider dentium in which the patients grind his teeth at the night time and patient feels pain when it get up. So soft night guards are to be given. Reminders can be given. As we can see here, there are attrition, the severe attrition in the dentition, pillowing habits, abnormal pillowing, chin learning and forearms. We can change it by repetition, repeating, telling the patient again and again to correct the position. Self mutilations, bob pin opening. These habits have now it's only commonly seen in girls because due to some reason they use this pin for their clothes. Clenching bruxism, I've already said about the clenching. Lip biting and lip sucking habits. For that, we can use oral screen. Chin popping habits and resulting. We have to ask patient not to do this again and again in the growing stage, as if he or she does each and every day on the growing stage, that The chin or the mandible will not grow in the correct position. Facial learning can be done. Musical instruments can be given. Postures to be corrected of the patient. Thank you so much for the lecture.